superficial blood vessels are cauterized with the help of cautery. Here is a patient who is having moderate to advanced cataract with pupil moderately dilated, not very well dilated. A very straight incision is given about 1.5 millimeter from the conjunctival disinsertion, and you go in a lamellar way, the way we do in SICS, and make the pocket so that it will help in nucleus delivery. Enter into the anterior chamber. Because the pupil was less dilated, I put weak adrenaline solution under the pupillary margin to have little more dilatation so that I can do without any iris manipulation or any procedure on the iris. The capsulotomy is done. I used to do capsulotomy, and here is a situation one can use dye to visualize the capsulotomy technique intraoperatively. I do not believe in that. In most of the situation we can manage, and here is a situation, capsulotomy is taking place actually under the pupillary margin and completion is done. After that, the hydro procedure is done in the usual fashion. Here is a large nuclear cataract, and a rotation is being attempted so that your hydro procedure is good. And some soft cortex is removed just to debulk. Because the capsulotomy was little, I'll say, moderate size, I made a technique that the one edge of the nucleus is out of the bag, and then with the help of Sinskey hook, you are rotating the large nucleus out of the bag. A very simple technique. It's the question of learning the trick so that you don't have to give any relaxing incision, and you can be sure that your lens is all in the bag. And then the visco-expression of the entire large nucleus. Here the incision is about 6.5 millimeter straight incision, and with the visco-expression, the nucleus is getting out of the wound. In difficult situations, there are procedures where you can break the nucleus, and you can do the nucleus removal in piecemeal, in few quadrant. Some more visco is injected to remove the epinucleus, and then the irrigation and aspiration technique will be done in the usual way. Lot of viscoelastic should be used to protect the endothelium, and you can see here now with the help of Simcoe's irrigation and aspiration cannula, residual cortex is removed, and make sure that the removal of the cortex is 100%. Once you complete the removal of the residual cortex, viscoelastic should be injected, and you can see here I am not using the bent cannula, J-shaped cannula. In situations where it is difficult, J-shaped cannula helps removal of the subincisional cortex in the upper part, which is lying behind the iris and in the capsular equator. Viscoelastic is injected into the bag, and then the lens is implanted. You can use foldable lens without folding because your wound is reasonably large, and you can really put the lens in the bag. Whatever lens you prefer is okay, but the power calculation should be good so that unaided vision will be very good. With the help of continued injection of viscoelastic, I am just trying to put the optic in the bag, and then with the Sinskey hook is doing the maneuver to put the upper haptic in the capsular bag. Make sure the lens is in the bag, and to check that in all quadrant. After that, the most important part of the thing here in relation to combined and cataract and glaucoma, I put a nylon suture in the anterior lip for the the anterior lip to be retracted by the surgeon, holding the posterior lip. An incision is given with the micro, instrument, and the trabeculectomy part should be done under direct visualization. 3 by 1 millimeter tissue or 3 by 2 millimeter tissue is removed. I prefer to make a good internal block. One can use punch to remove the deeper block to create the trabeculectomy opening. I am comfortable with freehand dissection, and then the iridectomy is done. Here one should keep in mind that the base of the iridectomy should be equal or even little larger than the base than the internal ostium made. Make sure that the iridectomy is seen properly, and then again irrigation aspiration of the viscoelastic material, and 2 sutures I use, one on each side of the internal ostium made. Just nylon suture. As I told, irrigation aspiration of the viscoelastic is done, and the surgery is nearing towards the end. One suture here, one on either each side of the internal block made. Just making sure that the viscoelastic trapped behind the lens and anterior to the posterior capsule is removed properly. And the closure here, I just do apposition, not too much tightness, just the apposition. One is probably little more tighter than the other. The other will be given little looser. An attempt should be made to make sure that the chamber depth is adequate and the gap between the suture is such that it will lead to some filtration in the postoperative period. Here I have not made any side incision or paracentesis opening. One can do that. In standard cataract as well as cataract and glaucoma surgery, I do not make any side incision. That's the way I do, but you are free to make paracentesis opening on either side to check the filtration, how it is happening. I do not really do that. Checking that intraoperatively has nothing to do with the postoperative result. The trick here is pull the conjunctival tenon layer, give permanent suture on each side here, pulling in a way and making sure that the conjunctiva is pulled and then the needle is passed, so that this part of the conjunctival tenon layer will press over the peripheral part of the cornea at 12 o'clock position, and whatever filtration takes place will be directed posteriorly. There will be no anterior leakage. I do not give any suture here, conjunctiva tenon with the peripheral cornea. Some people used to give. I believe in my hand this technique works very well. So this is the standard way I do, and I do not check how much filtration is taking place intraoperatively. Can you stop the video? Please stop the video. So you have, please stop the video. Close the video, is over. All right? So about the postoperative management, it is nothing different from phacotrabeculectomy. Standard antibiotic for a week and cycloplegic drop probably 3 to 4 weeks, 3 times daily cyclopentolate, and then steroid in tapering doses, starting say 6 times daily over a period of time. For a 6 weeks period, we stop the steroid. And the follow-up schedule is, we do the procedure on OPD basis. In the very first day, we open the patch, see vision, and then do check the intraocular pressure, and then prescribe medicine, call the patient after 1 week, and after that, again after 5 weeks, at 6th week visit, we do final refraction and give the refractive correction. Now, in case where there is borderline pressure or little on the higher side pressure, in the first postoperative day after removal of the patch and checking intraocular pressure, vision, etc., we give little digital compression to really check the efficacy of the internal ostium, how it is functioning or filtration taking place, and that is done under supervision in the slit lamp, retracting the upper eyelid with one finger, and with the other finger, you just press little bit at 6 o'clock position behind the limbus. You will see that fluid is collecting or the bleb is increasing with time, and a controlled pressure will give you an idea how much filtration you want to see in the first postoperative day. If your pressure is all right within, say, 10, 12, 14 millimeter of mercury, there is no need to do that. This I am telling, if the pressure is about 21, 22 or in that range on the upper side of normal, you do test that, and that test can be done in the 1 week visit, or even after that, within a month, it works very well. So this is the standard way I manage in the postoperative phase. This is, I feel that it's a very safe, simple, quick, effective, and inexpensive way of doing cataract and glaucoma surgery, where combined surgery is required. I'll stop here, and any question we can discuss in the end. Thank you.
Yeah, thank you, sir, for the excellent demonstration of the very meticulous surgical technique. We all know that your surgery is like a poetry. So